It's my pleasure to introduce my colleague, friend, Chad Brummett. Chad is an associate professor of anesthesiology, director of the Anesthesia Clinical Research Division, pain research, and as Sebastian mentioned, is really one of the fathers of MGI. So here in multiple roles, going to be talking to us today about opportunities and challenges in the study of opioid dependence and opioid use disorder. Chad. Thank you.
Well, thank you. I am officially a father of MGI, I guess. But I will take a moment because when we were starting MGI, I still remember when Gonzalo came to my office wanting to talk about MGI without really clarity on what we were going to do. I sort of threw out there the idea that we could collect 10,000 samples a year through the Department of Anesthesiology. And I didn't know what it would cost or how we would do it. I will give credit to George Mashur, who had done a prospective RCT of 20,000 patients collected over 2 years with a 90% follow-up. So I kind of knew what it meant to staff and run the ORs. And they are a unique space, but it is not a typical place to do research of this type, but it has been incredible. My early concerns, though, I must admit, were lack of use, that we would have this awesome resource and we wouldn't have people using it. And it really, truly warms my heart to look out in the audience today and see so many of you using it. And I guess I just ask you to keep pushing the bounds and doing more with it. And there's so many people out here that have become friends and colleagues over the years, and I thank you for everything you've done. I'm going to talk a little bit about opioids today. So I really don't know a lot about genetics. I've kind of hung around you guys and learned just enough to be dangerous, but I'll talk about what I do within the opioid space. And this is most of what I do, and I'm not going to go into great detail, but really, we've been really interested in outcomes. We've been interested in why opioid prescribing after surgery can lead to morbidity and how this could be an opportunity for prevention. And so we've done a lot of things to educate providers, patients. We've informed policy and done some payment reform. A lot of community outreach in terms of opioid pill drives and going for at-risk populations. And we even now have a musical, which was actually part of Precision Health with School of Music, Theater, and Dance. It's actually fully produced, and I got to see it performed a couple weeks ago. It's really powerful. It's going to be for high schools. So this is really actually what I do a lot of. I do try to spend some time with Matt and Albert and others thinking about the genetics of opioids, but this is really where I spend most of my time. This is what we put forth for the opioid use case. This was the concept for the opioid use case, one of the first approved use case for Precision Health. This idea that people become new chronic users after an opioid exposure that's really predictable. I could go to the pre-op tomorrow, and if I just had 2 weeks of data from before, I could tell you who's going to get an opioid and how much they're going to get just based on who's caring for them and the kind of surgery they're having. We really don't do anything when it comes to precision prescribing as it relates to opioids, and yet we know people are going to get exposures. We don't really know who's at risk. We see a lot of patient-level factors that appear to be like some phenotypic factors, but the associations are modest, and I can't really say that based on that I could really define or do precision prescribing. And so this idea was that if we could intercept here, if we could think about prescribing in that acute care space, we could really potentially have a preventative effect. And these are the data for outcomes. And so this is new chronic opioid use, or this idea of new persistent use after elective surgery. We give people not using an opioid before surgery, and these are the estimated rates of how many of them will become new chronic users. Now, some of these data are a couple years old. We do think we're making a dent in this by just changing how we prescribe. But when I'm talking to surgeons out there, I spend a lot more time on this slide, and I say becoming a new chronic opioid user is by far and above the most common complication after elective surgery, and yet something we've not really thought about until about 2 or 3 years ago. And these are the estimated rates, and we've thankfully seen these rates to hold up in MGI. So what we're seeing in our own local population appears to be pretty comparable to that 6% number on the top where we probably got our most press. But bottom line, it doesn't matter what surgery you're looking at, the patients, some portion of that patient population will go on to become a new persistent user. We've actually done a little bit of work, this is not unpublished, this is now out in JAMA Surgery, where we just looked at phenotypic factors of who's using opioids before they come in. And what we know is that there are certain patient characteristics associated with opioid use before surgery. So among those people coming in for surgery, and so we could think about this as a little bit of an epi experiment, but for a care-seeking population. And what we see is about 20% of patients are using opioids in some capacity before surgery. And that's pretty common, and that mirrors the national data. We see it more in orthopedic surgeries, spine surgeries, pelvic surgeries, and some orthopedic surgery. And then when we look at what characteristics we see in these patients, it's not overly surprising, but these are a more challenging population. We see higher rates of substance use disorders, more comorbidities, so they're just sicker patients, sleep apnea, so something we really wouldn't want people to have if they're getting opioids, lots of anxiety and depression, and lots of widespread pain. So these are kind of characteristics or factors that we really wouldn't want to see in an opioid user. And the orthopedic surgery and neurosurgery see very high rates of this. If I took abdominal surgery, it'd be about 10%, but it's probably 60% of spine surgery patients come in using opioids at some level on a daily basis. And so when I'm out there in the community, I'm talking about what we do for MGI, that number is closer to 70,000 participants. We know about 80% of the people for whom we care are opioid naive before surgery. And when we first brought this together, the idea was that we'd link their EHR data and our data that we have from the patient-reported outcomes that we've collected over time with SureScripts, which is a national prescription fulfillment data set. We're actually kind of using that, but there's new opportunities with their genetic data to ask this question, is there an association between that exposure and new dependence? In other words, can we find genetic associations between that early exposure and this idea of new persistent use? And so that's what we've been working away on, and Matt and Albert and Evan have been working diligently on this because it's not easy. So why hasn't this gone faster? Well, these data are sensitive data. We could go to the EHR and we could pull all the opioid data out of the EHR and we would have a flawed data set. Many people don't get their primary care here. We have an enriched cancer data set. Bramar knows how many cancer patients we have. Well, that's because people come here for cancer care. And then they go back to their community for their primary care. And so this idea of new persistent use is great if we could only know who's actually getting an opioid. And so I'm actually proud of where we are. I'm a little sad that we're ahead in this space because Matt can certainly attest to how hard this has been to get these kinds of data. But we had to come up with a system. So we have state policy, state legislation precluding the use of our prescription drug monitoring program data. So this is a national database of all controlled substances, opioids, benzodiazepines, sedative hypnotics. Each state gets to define how that data can be used, okay? And we, as a state, have legislation that says that we cannot link identifiable data for the purposes of research, with some caveats. So I started working with our licensing director about 3 or 4 years ago, helping her with some other policy. And I guess the reason I bring up how we got here is because I want you to think about how relationships matter, especially if you're younger in the crowd. The relationships matter a lot. She needed help with how to put forward new policy, and I helped her with new policy. And then she asked me in one phone call, she said, "What was that thing you needed again?" And the whole conversation changed. And so we actually have the first data sharing agreement, and we've received the first and only to date identifiable linkable data of the PDMP of anybody in the state of Michigan. The idea was that we'd use our honest broker office. We would derive participant IDs. We would take those participant IDs and send them to Erin Kaliba's office, the honest broker office. She then takes and puts an encryption key and the participant IDs together, and she sends that to APRIS. APRIS now has all their PHI because they need a lot of PHI to be able to do a probabilistic matching of which patient is in which data set. They then strip out the PHI, they put in the PDMP data, which is 5 years, because that's all our state is required to hold, so they only keep 5 years with the PDMP data, pull out the PHI and send us back that data set to the honest broker office with an encryption key and the PDMP data. From that point forward, now Erin's office has the data. We want to do something with it. We then have to derive our phenotype and outcomes data set. We send that to Erin, and so we're sending it with our identifiers. She then links it. She takes that phenotype and outcomes data set along with that encryption data set, and she pulls it together into a final data set that we can use for research. This sounds easy, but this has actually been a process and a learning process. And I was just telling, because we just got a second data dump, and so our challenge now is that we have encrypted NPI numbers, which is the provider ID, and an encrypted pharmacy number, which is the number that identifies each pharmacy. And the challenge for us now is they use different encryption keys for our two data dumps, and we can't merge the data. So we have to remember that within MGI, one value add is that this is a living data set. Patients are having more care, they're filling more scripts, and so we're trying to bring in new data, but anybody who's managed it will know that data is not simple to manage. So this is our idea, is that we will be able to pull this together. And we've done this once as a proof of concept. The data set was fairly small. We're hoping to grow it. So if I sort of talk about what I think we can do going forward as it relates to opioids, these are the concepts that some of which we're exploring and some of which we're not yet exploring. This idea that for surgery, opioid users versus non-opioid users, really thinking about using that care-seeking population to look at if there's genetic associations to just pre-op use. We haven't touched benzodiazepines, but there are certainly a hot topic that's coming. We talked a little bit about opioid efficacy, understanding the people for whom opioids work. Side effects and likability. Likability might be we may struggle to say which patient's going to become addicted to opioids, but that idea of how much people like opioids or dislike opioids and how much side effect they get may be a really important hallmark into what happens. And so I'm excited to explore that data, and that data set's growing. And then obviously the thing we started with is new chronic opioid use, but even efficacy of chronic opioids, misuse, and then lower incident outcomes that probably aren't realistic for the foreseeable future, like overdose. So this is where we are, and these are the things we do. These are all the people. So if you want to know like who collects all those blood samples, it's like a lot of these people. They go around and badger all the nurses every day to get more and more blood samples. So they're a great team, and they do a lot of great work to bring it in, and they deserve all the credit. So with that, I think we have a few minutes for questions. Happy to field any. Thanks.
When you refer to opioid efficacy, what kind of phenotype or outcomes data are you collecting? Is it just whatever's in the medical record, or have you done some patient-reported outcomes type things? And is there any plan to expand that to outside of analgesia and opioids?
Yeah, I think, so right now we have a fairly manual process through which we get prospective data of patients after surgery. It's in a subset of the MGI cohort and the study that actually predates MGI. And we've been able to get efficacy data at the 2-week mark, sort of asking people how helpful they were. And there's a few different questions we've designed to kind of get it. They're 11-point Likert scales of efficacy. They're imperfect. We now have launched an app. So for those that don't know, we developed and launched an app. Most of the people coming in MGI going forward will ideally be in this app. It's been a soft launch because this is not easy, but the idea is we'll also be able to get more rich data. So for those not interested in opioids or pain, the idea is that we'll work with Brummett to come up with a more rich data set that they'll then maybe better mirror the UK biobank at a later date. So we are trying to get more rich data over time and then more patients. But right now we have a fairly modest, probably 3,000 patient data set with some of that, and we haven't explored it yet. Great. Thank you guys so much.
Oh. Tell us about the play.
Oh, yeah, sorry. So
We still have about 5 more minutes.
Okay, so the way the musical came to be is I went and gave a lecture at community high school to a bunch of juniors and seniors, way more intimidating than talking to you guys. And I asked them, I said, how many of you could go home and within an hour access an opioid? And 75% of the 100 kids in that class immediately raised their hand without any hesitation. Now, do I think that means 75% of the kids were using opioids currently? No. They talk about it, they think about it, they know where they are. It's actually super easy to get opioids. This is why our group works so hard on disposal, because I can tell you right now there's a sizable portion of this audience that has unused opioids in their medicine cabinet. And this is the way most kids start. They experiment. There are pill parties, Skittle parties, there's all kinds of names for these parties. And I realized in that moment that we can't do like I don't care your political affiliation, we can't do Nancy Reagan, don't do drugs, right? Like that wasn't gonna work. So I reached out to School of Music, Theater, and Dance after seeing them perform. Gonzalo and I had gone to Grand Rapids to do a development event about precision health, and I got to see them perform, and these kids are unbelievable. School of Musical Theater gets 1,600 applications for 22 spots. And they got 20 of their 22 top candidates this year. So they're super talented. They wrote a musical based on real stories. It's intended for high schools, and we have now partnered with Michigan Department of Health and Human Services to actually formally test this in the opioid curriculum. So there's a new state high school opioid curriculum, and this will be tested as a modification. And we're working with Andy Eisman in your school to do a pre-post assessment. So we're gonna do a cluster randomized trial of 10 high schools to see if we're actually getting kids and we're actually making them think differently. So it's super exciting. Clearly was part of my long vision that we were gonna be part of a musical. But it's been a fun ride, and the music is super, super, super powerful. So we'll have a cast album out soon, and you guys can download it and listen to it, and then hopefully use it to talk to your kids.
Why wouldn't you want a patient to have sleep apnea?
Oh, so opioids actually blunt the CO2 response. So patients with sleep apnea already have altered CO2 thresholds. So CO2 thresholds are what trigger a person to actually to breathe, I'm sorry. And so opioids blunt the response to becoming acid. You become a little acidotic, and it triggers your midbrain to say, okay, we need to breathe a little faster. Opioids blunt that response. And so, and then if you get an opioid and now we pepper in a little benzodiazepine and you've got sleep apnea, or you don't know it, because many don't know it, then you can really have a bad outcome. So these are the dead in bed outcomes that we hear about every year. Somebody thought their family member was just sleeping on the couch, sleeping funny, and then didn't wake up. So this happens, unfortunately, every day.
Other questions?
This is a super hot space. If you're young and you're looking for a space, there is no space hotter than the opioid space right now. And we are eager within Precision Health to have people leverage this data set. We've had an analyst spend almost a year and a half coding and cleaning a data set that's very, very close to being able to be explored further. So we certainly have work planned for that work, but I'm happy to partner and do more work.
Great. Thanks, Chad.
Thank you.